if I took a child to an pediatric endocrinologist and say, you know, my son Stevie here, since he was 5 years old, has thought of himself as an Olympic athlete. And he did really well in grade school. And he did really great. He was all state in high school. All state in high school, but he's trying to get onto the Olympic team. He can't quite make it. He can't quite. And all his life, he's invested in the idea that he is an Olympic athlete. Can we give him some androgen? Can we give him some performance enhancing sex hormones? Well, that endocrinologist would be handcuffed if anybody found out that he was giving that child sex steroids to improve their performance so they can get on the Olympic team. It is exactly the same thing. The child invested in an identity, and you're going to the endocrinologist. Well, we've got laws all over the books protecting that child from that kind of abuse. And you're not going to do it in the case of a child who has cross-sex self-identification because you don't want to interfere with the doctor-patient relationship. You, sir, are a coward if that's the way you legislate. You're a coward and you're weak. I've been in the world of surgery and plastic and reconstructive surgery for over 30 years. And primarily in the field of reconstructive surgery, most of my time in the Navy, doing trauma reconstruction, congenital deformities reconstruction, that sort of thing. And I had no interest in transgender surgery because when I was in training and growing up in the field, it was a very, very, very remote and very small part of the specialty. There were a couple of places where surgeons were doing it. They weren't reporting much of it, but it was going on, and I knew about it. And I thought, well, that's a peculiar thing, and I didn't really give it a whole lot of thought. But in the last several years, it's become a huge process, a huge part of the world of plastic and reconstructive surgery. And you see it presented in national conferences and even regional plastic surgery conferences, people setting aside, a half day to talk about the various aspects of transgender medicine and surgery. And my professional organization that I had been a member of all those years has become a very strong promoter of it. And that was a grave disappointment to me. Now, how I personally came to be a speaker on the subject is an interesting story. I had gone to a retreat in Birmingham and met a priest there who invited me to participate in the Courage Apostolate. And I went to a national meeting, and while I was at the national meeting, there was a breakout session for clergy. And during that breakout session, a priest in a Roman collar actually said, "Don't you think it's very likely that eventually the Catholic Church is going to catch up with the science and that we will realize that same-sex attraction and transgender surgery is just part of the spectrum of the human experience?" And I made the mistake of raising my hand and correcting the man. Well, after having corrected him, Father Paul Czech said, "You should put together a talk for priests with your plastic surgery experience to talk about the realities of transgender medicine and surgery." And that was in 2014. And so 7.5 years later, it's become probably the majority of what I do professionally and personally is public speaking and presentations and expert witness and chapter writing and that sort of thing. So I didn't go looking for it, it came and found me. The first thing I would correct is that there's nothing about transgender surgery that is reconstructive. Okay, one of the important distinctions that one makes in the world of plastic surgery is that there are two sort of broad areas of the practice of plastic surgery. There's what people call cosmetic, or what is better termed aesthetic surgery. Surgery that's aimed at correcting minor imperfections that affect a person's interior life, something that they have to deal with every day, like a boy with very prominent ears. A very simple, low-risk correction. It just changes the way people interact with him on the schoolyard. That's an example. Or somebody with a hawkish nose that doesn't fit their face. And anyway, these are relatively simple things. Reconstructive surgery is surgery where there's something missing because of trauma, congenital deformity, cancer therapy, or something like that. You're reconstructing something that belongs there, for whatever the reason for its absence. And what animates both is that there's a consideration of both form and function. You're always addressing form and function. If you're primarily doing an aesthetic operation or a cosmetic operation, you're addressing form, but you would never sacrifice function in order to achieve an improved form. It's just contrary to the animating principles of plastic surgery. Likewise, when you do reconstructive surgery, you're balancing form and function. In a hand injury, function trumps everything, and you'd accept a less than optimal aesthetic result for the sake of a good functional result, say in a man who mangles his hand in a farm implement injury or something like that. But still in all, you strive for aesthetic perfection, even though your primary emphasis is a functional result. But you would never intentionally sacrifice normal human function for the sake of a cosmetic result. And this is essentially what the transgender surgery world is doing. They're sacrificing a native human capacity, a natural function, healthy parts, for the sake of achieving a cosmetic result, which is really a counterfeit. You don't actually construct the opposite sex genitalia. Nobody constructs that. What they construct is a counterfeit. You're creating a counterfeit genital looking like structure for the sake of solving an interior emotional aesthetic problem. Okay? So it's actually the inverse of the moral life of the plastic surgeon. It's the opposite. You're actually sacrificing a functional result. You're deconstructing, not reconstructing, you're deconstructing a human person to address an aesthetic subjective problem. And if you read the science, if you read what they call the scientific literature claiming benefit, like they'll say something like, well, people who have fully transitioned surgically are living a better life. Well, you read those papers and the language that they use is the language of cosmetic surgery. It's all a subjective result. It's a patient satisfaction survey. Well, they justify the operation because they claim that it lowers your risk of suicide, lowers your risk of self-harm, and that sort of thing. And that's an actual objective quantifiable thing, but they never address that in their results. They claim you're doing it to reduce suicidality, but when they look at their results, they'll look at a 2-3 year result with a satisfaction survey, the same way we would a satisfaction survey with a breast augmentation or a rhinoplasty or something like that. That's how aesthetic surgery is evaluated, because it's subjective aesthetic results you're looking for. And so the data gathering is all subjective. But when you're talking about quote unquote life-saving surgery, that's objective. You should be able to say, well, persons who have transitioned, what's the likelihood that they're abusing alcohol? What's the likelihood that they've been incarcerated? What's the likelihood that they've been in a psychiatric hospital? What's the likelihood that they've killed themselves? Well, the international literature on transgender surgery never addresses that problem, save for a few shining examples. The Swedish database, for example. But in the American transgender surgical world, short follow-up, self-selection bias, subjective results. Utterly meaningless. One of the key moral problems I find with the transgender treatment industry, and that's really what it is the way they're addressing this issue in children. And it's a process of literally grooming the child to think a certain way. And one of the things that they emphasize is that you have to do affirmation care. You have to encourage the child in their cross-sex self-identification. You have to encourage them in all of those aspects of transitioning, because if you don't, they're likely to harm themselves, if not kill themselves. And the parents will be bullied. They'll be bullied by this medical establishment that's telling them the whole time, well, your child is in grave danger. It's a good thing you brought him to us because we're going to save your child's life with affirmation care. Well, if you have a child who's anxious and you have a child who's depressed and you give them affirmative messages, it's a great thing for a child. To hear adults giving them affirmative messages is naturally good for any child. But the content of the message that the child is hearing is what's problematic here. And the content that the parents are hearing is even more problematic, because parents will hear such things when they're trying to make a decision. Should I start my child on puberty blockers? Should I start my child on cross-sex hormones? It's not unusual for the parents to hear a professional say, well, I know it's a tough problem, but we have a lot of experience with this, and which would you prefer? a live son or a dead daughter. And this is what parents are hearing. They're being groomed with the idea that without affirmation care, their child has a 40% risk of suicide. Well, that 40% number is very much debated, and the reality is it's some number considerably smaller than that, but let's just grant them that it's 40%. If you look at the historic course of transgender cross-sex self-identification in children, if you take historically what that represents, historically over 80% of children who experience cross-sex self-identification were boys. And of those boys, that constituted about 0.02% of the population. Of those boys, 80% of them would get over it early in puberty. And by the time you got to young adulthood, 92% of them get over it. Right? If you put those children in affirmation care, 100% of them will continue on into adulthood believing that they were assigned the wrong sex. So you have to ask yourself, how is it possible that a professional organization, knowing that information, would be confident that they're treating the right children? Even if transgender were an actual biological reality, not a psychological, but a biological reality, how do you justify 100% of children going on to cross-sex hormones and possibly surgery when 92% of them would have gotten over it if you had given them what historically has that 92% benefit, which is basically what's called watchful waiting? It's cognitive behavioral therapy, family therapy. If you look at those children, you'll find that there's something in the family dynamic that the child has misinterpreted. And they think that they really are supposed to be the other sex for issues of safety or potential fear of harm or more love from the parents. It's a real scattergram of possibilities there, but we know that family therapy works and keeping the child in touch with reality works. That's what cognitive behavioral therapy is about, is reinforcing the truths, the realities of the child's life, not aiding them and abetting them in a delusional thought. It is a delusional thought. The word delusion I don't throw out there casually. All right? It's not a pejorative term to say that transgender is a delusional thought, because those words have meaning. Okay, and what is a delusion? A delusion is a fixed, firm belief. All right, the child fixedly believes they're in the wrong body. That's a fixed, firm belief. It's not amenable to objective argumentation. You can't say, well, honey, you're a boy, look at your body. It's not addressable by objective argumentation, right? That's the second criteria. The third criteria, and this is from the textbooks of psychiatry, by the way, the third criteria is it's impossible. It's impossible that a child who has a Y chromosome in every somatic cell of their body is a girl. That's a reality. That's a reality. It's an impossibility. So that's a delusional thought. You don't encourage delusional thinking in children. It is an unhealthy thing to do to a child, because keeping a child in contact with reality is part of their formative process. It's one of the responsibilities that parents have to their children. And that aids them in developing higher executive functioning and decision making and stuff like that. To be living in a delusional thought process and to insist that everyone around you aid and abet that process is utterly beyond healthy for anyone. No one is served by a delusion. And certainly it is the case that if you claim to call yourself a good psychiatrist or claim to call yourself a good plastic surgeon, if you don't make it your business to deal in the truths of what it means to be a human person, you're not serving that individual at all. Because evidence-based medicine, evidence is an objective reality. Evidence-based medicine is sort of the bulwark of good practice. And it's about to come tumbling down on the transgender treatment industry. And in fact, there is a condition that plastic surgeons are trained to recognize. It's part of our development and training as plastic surgeons. It's a condition called body dysmorphic disorder. And body dysmorphic disorder is a condition where a patient will present typically to a plastic surgeon. And then they may present with some fairly ordinary kind of a question like, well, I'm interested in having, well, let's use your example. I'm interested in having a rhinoplasty. I want you to change the appearance of my nose. Well, Well, this is a common reason for consultation with a plastic surgeon, and you review their history and you're talking to them, and while you talk to them, you're trying to get an understanding of their motivation, and while you're trying to get an understanding of their motivation, you're actually looking at their nose without being obvious about it, but you're looking at their nose and you're kind of sizing things up. And there's certain things that I know about noses and faces and the balance of a face, that it should be a fifth the width of the face, that it should be a third the height of the face, that it should have a certain contour if they're a masculine face and a certain contour if there's a feminine face, because that's one of the natural effects of adult hormones, is to change the bony facial and cartilaginous structure of the face, and there's more masculine and feminine, whatever. So while we're having this conversation with the patient, I'm assessing their nose. And the person with body dysmorphic disorder, you'll be looking at them and listening to them and trying to understand what their motivation for surgery is, and they'll be describing a nose that to them looks like a horror. And they'll start saying things to you that suggest that they think that everything that's wrong in their life is the result of the contour of their nose. They're convinced that the reason they're lonely is because women will look at their nose and think, what a horrific, this is sort of the Cyrano de Bergerac withdrawal thing. Or they'll think that the reason they're not getting promoted at work, or the reason why, life is a misery, is because of the contour of their nose. And what they're telling you is that they're so invested in what you're going to do to their nose that they expect it's going to be life-changing. That if you correct their nose, all of their sorrows will go away. That's the key. And so essentially what they're asking you to do is to solve an interior wound by changing their external appearance. This is a common psychological process that I see in children. Very often I get consulted on children who have been harmed in some way. I get the call from the ER at night saying, I'm seeing a child whose arm got bitten by a dog, and we would just want to send him to you for follow-up. And so 2 days later, the child shows up with the parent. They have a bandage on their arm. They've been wounded. One of the things I have to do during the course of that visit is I have to take the bandage off the arm. Well, the last thing that child wants to do is look at that wound. The last thing they want you to do is to take that bandage off, because the bandage is keeping them from having to look at it. This is what happens to interior wounds. Sometimes they are so terrible that the last thing the person wants to do is examine that. And so they look for an external explanation for their sorrow, and they'll ascribe their interior sorrow to an external trait. That's body dysmorphic disorder in a nutshell. And so they'll come in with a delusional thought. The anorexic example that you gave is the girl who comes in, a woman perhaps, who comes in seeking body contouring, liposuctioning, because they see themselves as obese, right? They have a delusional thought. And no amount of argumentation from you is going to convince them otherwise. You can tell them, well, your body mass index is less than 10%. There's no way you could be obese. They won't hear it. They won't hear it. And it's impossible that a person with 10% body fat is obese. That's the impossible, right? Remember the 3 criteria: fixed, firm belief, not amenable to argumentation, and it's impossible. This is the case with transgender. The person has an interior wound and they're seeking an external explanation for it. It's not their body mass index or the contour of their nose, it's their sexed self. They ascribe their gender presentation, they invest in that, the explanation for all of their sorrows. And they want you to change it, thinking that if they change it, all will be well. It's the same process. And it is malpractice in the world of plastic surgery to do, repeated rhinoplasties on somebody who keeps coming back because they haven't quite got it right. I mean, Michael Jackson's a wonderful example. Interior wound seeking an external explanation. And if you follow him from his childhood to the last of his days, you can see his nose changing and changing and changing and changing. Why? Well, if you do surgery on somebody like that, they'll be happy for a while. And then they're not happy. Why? Because you didn't address what was really wrong. And then they'll come back and say, well, you didn't quite do what I thought you were going to do. Let's revisit the problem. Or they'll say something like, well, I went to this other plastic surgeon, but he didn't understand what was wrong. But you're a great plastic surgeon and you're going to fix what's wrong. These are all bells that should be going off in the mind of a plastic surgeon when they hear words like that. And you do not offer aesthetic surgery to a person with body dysmorphic disorder. It is considered a misdiagnosis. You missed the diagnosis and you did the wrong thing for this person. You didn't serve their best interests. You may have served your cash register, but you didn't do that person any good at all. If you just follow them for a little while, you'll think you're the greatest physician and surgeon that ever walked the earth. I've solved these problems on suicide. I've prevented suicides. Well, yeah, you follow them for 3 years and you're going to think you hung the moon, especially if your data gathering process doesn't seek out every patient you operated on. If you just seek out the people who happen to walk back in your office and to talk to you about their transgender surgery, well, that's called a selection bias. You're basically talking to people who haven't killed themselves, obviously, and people who are happy enough with their result that they decided to come back and see you. Yeah, if you did 100 operations and your follow-up only includes 22 people, well, what happened to all those other people? Are they in a psychiatric hospital? Have they been incarcerated for a violent crime because they've been taking testosterone for 5 straight years and now they're roid rage? Have they killed themselves? These doctors wouldn't know because they didn't go looking for them. But the Swedish database has saved the day for us because healthcare in Sweden, every event of healthcare gets entered in the same database from womb to tomb. You're entered in the database while you're still in utero, and you're kept in the database until you reach room temperature, basically. Every event of care, whether you're in a prison hospital or a public health clinic or a private plastic surgeon's office, every event of care, and it's in the same language, the same descriptors, all of the things are entered the same way. And so you can go into that database and actually ask some important questions. You know, if you have a 27-year-old transgender male who's just been hospitalized for alcohol toxicity, you can ask the question, well, what's the likelihood that a 27-year-old male from the same demographic, lives in Stockholm, middle-income person, what's the likelihood that he's an alcoholic? Now you can answer those questions that nobody seemed to want to ask. What's the likelihood that a fully transitioned person is abusing alcohol, abusing drugs, abusing people, harming themselves, committing suicide? What does that database show? Well, it shows us that if you only follow these people for about 3 to 5 years, you've done them a world of good. But there again, as you pointed out, you get beyond a certain point, and they're no longer hearing the affirmative messages because people are tired of revisiting that issue after 5, 6 years of, oh, you're beautiful, you're wonderful, you're your authentic self, and all that stuff. That hubbub dies away and the interior wound is still there. And if you look beyond about 8 years, the suicidality rate is right back. Fully transitioned, taking all patients fully transitioned, they have a 19 times higher rate of suicide than the general population. That's not a cure. That basically puts you in that what they claim is the 40% likelihood of suicide rate. You're right back there. And the only difference is now you've got a suicidal patient whose genitals you've mutilated. That's the only difference between those two groups, right? Because you haven't addressed the interior wound. That's the important problem. And that only makes sense. I mean, how are you going to heal a wounded heart by operating on people's genitals? And yet, my profession fully embraced that now. This is one of the great shortcomings in the world of the transgender treatment industry, is the role that the plastic surgeon plays in that whole process, which begins perhaps with puberty blockade in an early adolescent child and has now gone through cross-sex hormones and social transitioning, and now gets that referral letter from this licensed social worker or the psychologist saying, this is a fully, transgender person, go get him. I've reviewed medical records for litigations of various kinds, reviewed the medical records of various plastic surgeons who are big in this world. And what you find is that there's no diagnostic process for the plastic surgeon. Essentially, if you walk that whole process back, the person making the diagnosis in many cases is a pre-adolescent child who's suffering from profound anxiety and possibly depression. And they're the ones who made the diagnosis because nobody gave them the contravening reality check like cognitive behavioral therapy might. They were all encouraging this child. So essentially, the plastic surgeon is getting preoperative consultation and consent for perhaps a mastectomy in a 15-year-old girl. I mean, the WPATH recommendation, version 8, is now going to recommend that you can do mastectomies in 13-year-old girls, okay? So you've got a 13, 15, 17-year-old young lady who's going to have a mastectomy, and the plastic surgeon is relying on a diagnosis that was made by that child perhaps 10 years before, and nobody has waved a flag on this and said, wait a minute, what are we doing here? The plastic surgeon at that point is a technician, and that is contrary to everything I learned as a surgeon. I don't care if you're a general surgeon or a plastic surgeon and a Nobel laureate in endocrinology sent you a referral. It is your duty to make sure that that diagnosis is correct. I mean, if I had done a removal of a colon because some pathologist said, yeah, that's colon cancer, I'm going to want to see the pathology report. I don't want to remove this man's colon just based on some printed document. I want to make sure that I'm not doing the wrong operation on this person. And yet you have plastic surgeons on the word of a child passed through a licensed social worker, a social worker who's not a doctor, sending a letter saying, yeah, this is a transgender child. Again, is that child maybe one of those 92% of who would have gotten over it? I mean, assuming that transgenderism is a reality, which I don't grant you that, but let's just assume, for the sake of this argument, that that's a reality. Is it possible that this is one of the 92% who's going to change their mind? How do you know? How do you don't know? And yet they're doing it, and they're claiming wonderful results. You have the director of the gender clinic at USC actually publishing papers claiming benefit of mastectomy in children and young adults based upon a satisfaction survey instrument. Again, no objective test, satisfaction survey instrument. And the instrument was devised partly by the children themselves. The questions to ask, because it's all that broad-minded thing that animates this strange world. An unproven diagnostic instrument, an unproven test instrument, partially designed by the patients themselves. That paper is published in a peer-reviewed journal, and it's claimed by many people, including people from Stanford and articles I've read, claiming that as medical evidence that mastectomy in self-identified transgender males, females wanting to present as males, that mastectomy is beneficial. Utterly insane. Historically, the majority of the children were boys who self-identified as girls. The new demographic is adolescent female self-identifying as male, beginning in mid-puberty perhaps and on into like early college years. And what's amazing about that, first of all, is that there's been a 5,000% increase in the diagnosis of self-identified transgender females seeking to present as males. And what you find when you look at that subset of patients is that they have a 30% likelihood of being on the autism spectrum, right? Talk about capacity for being misled by social signals and things like that. If you look at that same group, you'll find there's a very high likelihood that they have clinical depression or clinical diagnosis of anxiety disorder. And yet these licensed social workers and psychologists never mention that except as an impediment to transitioning. They'll say, well, this person has major anxiety disorder, but we're going to help them get over that major anxiety disorder so that they can go on and transition. Never once anywhere in that medical record saying, we think we're going to get them over the anxiety disorder so they'll stop this cross-sex self-identification. Why not ask that question? Why not ask yourself the question, why is it that all of a sudden there's 4 girls in the same middle school who are all self-identified males? How did that happen if it's a biological reality? How is it possible that there's a 5,000% increase in a diagnosis like that if you think it's biologically caused? Was there some like asteroid that hit the Earth and caused a massive mutation in the human genome? What happened? Is there something in the drinking water in our town that's causing all of these young girls to think they're boys? Nobody is asking questions about biological realities because they know it's a psychological process and they don't want to address that. This is the reason why the language of transgender has been intentionally modified to take away. It's called depathologizing. This is what the Diagnostic and Statistical Manual did 7, 8 years ago is they changed it from gender identity disorder, which obviously smacks of a psychological problem. They call it now gender dysphoria. And really, and all they'll allow you is that the person's unhappy, but they're unhappy because of a biological reality. This is the problem that the psychiatry world, the psychology world has faced. They don't want you to think of transgenderism as a psychiatric, psychological process that the person is suffering under, right? But yet they want to bill insurance companies. They want to bill the public insurance. So it's got to sound like a medical condition. So they came up with gender dysphoria, and all the while they're waving their hands going, but this is not a pathology. This is just, it's kind of like a diagnosis, but it's not a pathology. Well, if it's not a pathology, why are we amputating people's genitals and breasts? What's that about, right? Is it an objective reality or not? And if it is an objective reality, why are you operating on their genitals? That's the other question. I raised this issue with an advocate for transgender surgery. I said, since we stopped doing frontal lobotomies, nobody has done surgery for a psychological problem. And he corrected me and he said, well, we do implants now for obsessive compulsive disorder. And if you stimulate the vagus nerve with an implanted stimulator, you can manage bipolar disorders and things like that. Well, not even realizing what he just said is like, yeah, well, you're operating on the affected part, which is the central nervous system. First of all, you're not mutilating the central nervous system to do it. And you're not operating on their genitals, for goodness sake, right? You're actually in the central nervous system working on a cranial nerve to do something to the brain in order to affect a psychological process. He didn't even see that. He thought he had one-upped me by saying, oh yeah, we still do surgery for psychiatric problems. And in the process of doing that, he admitted it's a psychiatric problem like obsessive compulsive disorder. We operate for obsessive compulsive disorder. Oh, okay, but this is not a psychiatric disorder. It's just unbelievable circular argumentation you get into these people. I spent a lot of time in my professional career training medical students and surgical residents and various people. And I've noticed a change. I noticed a change over the years that the more recent graduates of medical school are more fact-based, memorize the facts so that you can get it right on the test, carry it around on your phone, rehearse the facts, check the facts, get the facts, enter the database, put it in the medical record. Very little in the art of seeing the person, understanding the person, and making wisdom-related decisions. The wisdom has been sucked out of the medical world, and it's become a technical exercise. And medical students now live in the world of algorithms. And you have algorithms that drive everything from emergency room visits to psychiatry visits. Why? Because if you want to get paid, you better be following the algorithm, and the attending physicians and surgeons know that. So the medical student has to fall in line with that. What's the next step? Well, a child comes in with anxiety disorder and ask them if they're wearing mommy's clothes, and then you just, okay, so you can make the diagnosis they're transgender. Let's get them to the gender identity clinic. And it boom, boom, boom. And nobody's really exercising wisdom any longer. They're managing an algorithm that's entered into a database. And the driving force for that whole thing is third-party payers and essentially insurance processes that protect you from malpractice. The world of the independent physician is vaporizing under financial pressures. And one of the main effects of that is that physicians are now in multi-specialty groups, large group practices that are managed by office managers, practice managers, and it's driven by financial concerns. So they have to see many patients in a short period of time, and every one of those visits has to make sense from the standpoint of diagnosis and procedures, all of it leading towards billing. If you're going to bill for this procedure, you better have had that diagnostic test. You better have made this diagnosis code. And so they're always living in this world of algorithms. Why? Because if they don't, the office manager will be in here shortly to read them the riot act. Oh, and by the way, you only have 3 minutes left in this visit because there's 18 people in your waiting room, because you have to see that many patients in order for it to make financial sense for that practice to have you there. Oh, and by the way, you've got a mountain of college and medical school debt you haven't paid off yet, good luck becoming a member, a partner in this practice if you don't pick up the pace.
Yeah.
So when you introduce a child who's anxious or depressed or something like that, and mom's wringing her hands, and everybody's whispering in your ears and whispering in the child's ear at school and the nurse at school who sent them to you, and they're all saying, we think this is a transgender child. Well, it's like, okay, transgender child, not my problem. Move them along.
Move them down the line.
Exactly.
Which is what they all do.
Yeah, and so maybe it winds up in an endocrinologist's office. Well, that's consensus-based practice when you're talking, which is the lowest form of medical evidence. You've got, these consensus statements from professional societies saying that the only way to treat a self-identified transgender child is with puberty blockade and cross-sex hormones. They write these consensus statements and fully on board with it. Well, what's a young endocrinologist going to do? He's going to take out 40 minutes to prove that this child is actually clinically depressed? No. He's going to say, okay, I have a partner who does trans stuff. Children at a very early age now are being sexualized. They're being asked questions about their quote unquote their gender or their sexuality and things like that. You have documents that are given to teachers to share with students at the grade school level, like the Gender Unicorn, which asks sexualizing questions. Why on earth would you ask a 9-year-old child who they're sexually attracted to, right? And so you ask a 9-year-old child, who are you sexually attracted to? How are they going to find that out? What does that even mean? Well, at that age, the people they're most attracted to look like them. When you were a 9-year-old boy, you preferred spending time with other 9-year-old boys doing boy things, right? You were in that latency phase, right? And you weren't interested in those exotic creatures over there, those girls. They were kind of annoying, actually. But there came a day, well, all of a sudden you sort of turn your head and go, oh, what's that over there, right? Yeah, but if you ask a 9-year-old who they're sexually attracted to, first of all, they don't have sexual attraction at 9 years of age. But if you ask them that question, how are they going to answer that question? Well, the way they answer every other question that a teacher raises in class, they're going to Google it when they get home. The average age that a child encounters hardcore pornography now is 9 years old. 9 years old. If you have a boy who's like slipping into adolescence, who's been surfing porn for a couple of years, right, and a girl shows up in school who's developing breasts, that girl's likely to suffer verbal abuse from that boy, right? That's another factor that's probably stimulating this desire among certain girls to not want to be girls anymore. Because as they manifest their secondary sexual characteristics, they're encountering this horror of sexualized, porn-saturated middle school boys or high school boys who make them feel like they're in danger. And if they just didn't look so much like girls, they wouldn't feel like they're in danger. They wouldn't be hiding out in the bathroom during lunch. That's another factor. If a girl enters the world of pornography, at 9, 10, 11 years old, the majority of what she's going to see is women being sexually horrifically abused. And what's the odds that an adolescent child is going to see that as a beautiful thing? Some number approaching 0. Yeah, little wonder that the level of gender confusion is off the charts, a 5,000% increase. That shouldn't surprise anyone. One of the things that we hear all the time from the proponents of the transgender treatment industry and affirmation care is that we need to follow the science, and that if you were a better doctor and you were more aware of the medical literature, you would realize that affirmation care and transgender medicine and surgery is the only way to go. Well, so I've been a doctor now for roughly 40 years. And in those 40 years, I've been to a lot of lectures. I've read a lot of textbooks. I've read a lot of professional papers. I've written some papers. I've written some textbook chapters. I have never in my professional life ever read a textbook, a journal article, listened to a lecture that described the human person as a spirit being that occupies a body. In fact, the world I grew up in is the world of materialistic scientific medicine, right? We're living in this materialistic worldview. And what it tells us, what it teaches us from day one is that the human mind is a product of the human body. That the complexification of the animal eventually led to what we call the human intellect. And finally, the body got complex enough to create a human intellect. And that's what animates all of modern medicine, is that idea, that sort of evolutionary idea, materialistic idea. Well, how do you jump from that to like, well, actually, no, you have the spirit identity person floating around, and they give these children the language. A 9-year-old child doesn't naturally say something like, well, I'm really a boy trapped in a girl's body. That is not the language of children. That's the rehearsed language given to them by adults who staff gender clinics, who have MD after their name. Where did they get that from? Where did they get that from? That is superstitious thinking. It is absolutely stupid, superstitious thinking that goes against all of Western philosophy that gave rise to the university and the medical school in the first place. And what is that? That the human person is a hylomorphic being. What does that mean? That's Aristotelian. It means that body and spirit together comprise a single nature. It's not that you have a spirit nature that fills what may or may not be the right body. And it's not that you have a carnal nature that gets complex enough but is separable from its spirit side. No, the two things together comprise the human person, human nature. The nature of the human person is hylomorphic. If you separate soul, spirit from body, I do know that there's a medical diagnosis for that. It's called death. And yet this is what we're being sold by the practitioners or the followers of science, that a person may or may not be born in the wrong body. Or the other term they like to use is was assigned male at birth, as if it's some sort of autocratic thing that we need to fill a quota. Well, we've had 7 boys born in the last week. We need a girl. Let's assign this one girl. That's moronic, absolutely moronic. You know, medical tests are judged by their predictive capability, right? You have, false positives, false negatives. What's the likelihood that it's a true positive, true negative? And you can gauge a medical test. Simple examination of a child looking for the male or female genitalia is correct 99.98% of the time. That trumps just about any other medical test I know of in terms of its predictive value, and it can be done by children, right? So that's not assigned. It's not assigned. It's a medical reality that any person could recognize, right? And it has positive predictive value. What do I mean by that? Well, making that judgment 99.98% of the time correct means that, well, I can predict that when that child reaches puberty, that child's going to grow a breast and become fertile within 2 years and have babies at some point in their life. Or that if I give them a certain medication, they're going to have a bad reaction to it because they're males, and it's going to cause, involution of their genital apparatus, or it's going to cause a muscle wasting or something like that. One of the key questions we ask when we take a medical history is the sex of the patient. If I was to pick up that phone to consult with another professional about a complex surgical case, there's several things he's going to want to hear right away. And this is how it would start. I have a 37-year-old Caucasian male. I have a 29-year-old Filipina girl who's recently arrived from the Philippines, who has a cough, has been living in the San Joaquin Valley, whatever. You want to know their sex because that's a very important piece of information. And to hide that under this subterfuge of gender reassignment is a grave danger. To have somebody presenting as a female and insisting that the medical records say that, who shows up in the pulmonologist office with difficulty breathing, and I get a chest x-ray and I see these nodules in their lungs, and I'm not even aware that they have a prostate gland, right? Because you don't take the prostate gland out when you do cross-sex surgery on a man to make him present as a woman. This man's got prostate cancer, and I don't even know that he's a man. I'm going to be fooling around going, wow, is this ovarian disease? Does this person have metastatic ovarian cancer? Or what's? It's bad medicine. And bad medicine eventually leads to big settlements. And that's where we're headed. We're involved in a lot of legislative efforts, but ultimately tort law is going to destroy the transgender treatment industry because it's bad medicine. It's bad, and you can't do that for very long. You might make a lot of money selling snake oil, but eventually the posse is going to catch up with you. And it's going to be lawyer v. lawyer, and they're both getting paid. Ultimately, it's an attack on the revealed truth of the incarnation of Jesus Christ.
Yeah.
Don't ever forget that. Because, I mean, if you think about the manifold ways in which the child and the family is being attacked right now, no human person could have come up with something like this. It is inconceivable to me that some cabal of human persons came up with something so overwhelming and destructive on children and family life. But ultimately, if you get this wrong, you get the understanding of the incarnation of Jesus Christ wrong. And for a child, if a child can undress and look at themselves in the mirror, look at their embodied self and say, that's not really me. I'm somebody else. That's not really me. Well, how can that child possibly gaze up on the image of the crucified Christ and say, it's very simple for them to say, that's not really God. It just appears to be God, but that's not really God, because God is a spirit creature that may or may not occupy the right body, which means that what he did on the cross was of no effect. Of no effect. That had to be a human person who suffered and died, but had to be divine at the same time. Incarnational theology. And this is gender ideology is an attack on incarnational theology.